Go away. Gay effect. Go. Get out of here. Get that.
Hi everybody, Ziv SImon. I'm here with Dr. Stanely Malamed,
Hi, Ziv.
professor of anesthesia, now retired from USC,
Thank God.
and thank God, great school. And,
Great school, but 40 years of teaching was almost a life sentence.
okay, life sentence, it's all relative.
It's relative.
So we have only a couple of minutes to ask Dr. Malamed a couple of questions. The first question that I wanted to ask you, what is the most common complication or problem that dentists have with local anesthesia,
Okay.
in your experience?
The most common problem by far is they miss. And the misses occur almost exclusively in the mandible.
Okay.
And usually when somebody is giving the inferior alveolar nerve block or mandibular block. And if you want to talk about tips or things you can do to improve that, is number one, on that mandibular block injection, higher is better.
Okay.
The most common reason we miss is simply being too low, where the nerve has already entered into bone. So number one, go higher if you miss the first time. Number two is learn alternative techniques. We have the Gow gauge, the Akinosi-Vazirani, the PDL, intraosseous. Articaine is a great local anesthetic when used by mandibular infiltration. It works nicely. And then now we have buffered local anesthetics. So any of those combinations are going to improve your success rate.
So there's no such thing as a patient that is resistant to anesthesia?
No.
There's no such thing?
Well, unless that they have a really severe infection.
Okay.
But other than that, you can get a patient numb with one technique or some combination. Absolutely.
Okay, great. Do needles really break?
Yes.
Does that happen, and how often does that
Well,
happen?
this morning I got an email from an attorney saying that she is defending a dentist who had a needle break. Actually, the term they use is the needle separated.
Separated, of
which
course.
is
They never break.
Utter
They only separate.
nonsense, because the answer is yes, they do. How commonly? Very rarely. I would say, and the reason they're so rare is that I get involved in the cases that if they were more common, you would hear, they would be commonplace. But I would say to you, in this case, okay, the broken needle, the separated needle, when you say a needle separates, you're thinking that there's two pieces of metal that are joined together in that thing called the hub. It would separate. Not true. There's one long piece of metal in there.
Okay.
The needle broke. And I would have to say that invariably it's because the doctor is using a 30 gauge short needle and on a technique where you shouldn't be using a short needle, which is anytime you're going down, you're going in more than 20 millimeters, you want to use a long needle. Because if a needle breaks, it'll always break at the hub. And if you're down all the way to the hub, the needle's gone and you're going to have a lawsuit.
So you have to visualize the needle at all time. You don't want to have it disappear the tissue.
You don't want to hub it. Hubbing would be all the way
Hubbing
in.
meaning all the way.
Yeah,
in.
and
Okay.
a long needle is 32 millimeters long, and on adult patients, you're not going to hub it. You're not, and it's as simple as that.
Okay, that's good to know. So what are you going to do now after retiring from USC? What's the plan? The big plan?
The big plan is I'm traveling. I've always traveled when I was giving lectures outside the university, but I used to have to stay in school to the end of the day, catch the last flight out, and then hurry up to get back to school. But now I'm going places. I'm going a day early, staying a day after, and I'm enjoying it more.
Okay.
So I'm busy as ever, but I love it.
Sounds like a plan. One last question.
Yes.
You're going to give a lecture now for the Nate Stewart seminar.
Yes.
I'm going to be lecturing after you. So give me some tips, because I'm the underdog. I'm lecturing after a prominent speaker. What should I do to do well in my lecture?
Keep them awake.
Keep them awake.
Late afternoon.
Coffee.
You're on from what, 3:30 to 5:30?
3:30 to 5.
Yeah, I'll tell you something. That's rough.
I know. That's why they put me there.
I'm a morning person. Okay, I'm good in the morning. I fall asleep in the afternoon. And judging by the age of some of these altacockers,
Yeah, of course.
We have a real chore ahead of us.
Good. I'll use some elbows.
There you go.
Dr. Malamed, thank you for your time. I
It's
appreciate
my
the time you
pleasure.
gave us, and we'll see you soon.
And you gotta love the Apple iPhone.
Yeah, we love it.
That's great.
Thank you very much.
Bye-bye.
Bye.